I'm Brian Saunders and this is Ahmad, and we are from St Mark's Hospital in London, and we're very pleased to present to you our latest paper, Nice Derived High Confidence Optical Diagnosis of Small Polyps compared to Histology, Understanding Errors to Improve Diagnostic Accuracy. So this paper is a sub-study of the DISCARD-3 study, which we have already presented, and there is a video available which outlines DISCARD-3 in detail. This paper is looking specifically at why experienced endoscopists make optical diagnosis errors when looking at diminutive polyps. In DISCARD-3, all small and diminutive polyps were assessed using both white light and narrowband imaging. And a decision was made around optical diagnosis, dividing the polyps into high confidence calls or low confidence calls. We wanted to look in depth and do a root cause analysis of why errors occurred in the group of polyps where a high confidence diagnosis was made. So Ahmir, talk us through exactly how we looked in detail at these smaller polyps.
Yes, so within the DISCARD-3 study, we optically diagnosed 1,560 polyps that were less than 10 millimeters in size, and of these, 1,169 were diagnosed with high confidence. Of the high confidence optical diagnoses, 184 of those, there was a discrepancy with the original histopathology result. And so a root cause analysis was performed of any case of optical diagnosis histopathology discordance. The discordant cases first underwent a review by an experienced histopathologist, a second blinded review, and then a series of deeper levels, first 6, then 9, and finally 12 levels was performed in cases where there was ongoing discrepancy. And if after that analysis there was still a discrepancy with the high confidence optical diagnosis, we undertook an expert photodocumentation review to determine the most likely cause of error.
So let's have a look at the results. So how did we categorise the errors?
So the errors were categorised into 4 different types of optical diagnosis error, and this was on the basis of the optical diagnosis compared with the histopathology report. So a type A error was where a serrated polyp was diagnosed as an adenoma, and that occurred in 34% of cases. A type B error was where an adenoma was diagnosed as a serrated polyp, and that occurred in 41% of cases. And then type C and D errors were rarer, and this is where the histology came back normal, but the optical diagnosis was either adenoma or serrated respectively.
So let's look in more detail at a type A error.
So type A error, that is an error where a serrated polyp is diagnosed optically as an adenoma, we found 2 key reasons why type A error occurs. The first is where there is a subset of serrated polyps which have a slightly unusual appearance, where you have elongated crypts that are not surrounded by a capillary mesh network, and so they at first glance appear to be adenomatous but are in fact serrated polyps. We've referred to these as pseudoadenomas because we think this describes what you can see, and they have a characteristic appearance.
And this is a new description of this subset of serrated polyp. And in my experience, you often see several of these in the same patient. They're not that common, but they are very easy to mistake as adenomas because they have this tubular appearance. But talking about the microstructure of the lesion, what are we actually seeing there in that tubular structure?
For a pseudoadenoma, which is a term that we suggest, the surface pattern is similar to a true adenoma, but there's a lack of the capillary network that surrounds the crypts. And so optically, pseudoadenoma is in fact the inverse of an adenoma, and that is that in an adenoma, you have crypt openings within a white structure. whereas in the pseudoadenoma, the crypt openings appear dark and are surrounded by white intercryptal structures.
Any other reasons why we make a mistake thinking something is an adenoma when it's actually serrated?
Yes, so another reason for type A error is where there is traumatized polyp surface, and that is particularly common in rectal and sigmoid polyps. And the trauma occurs because of the propulsive forces in this part of the bowel, which can affect the surface and increase the vascularity of the polyp surface, and therefore under narrowband imaging it can result in a type A error.
So it appears darker than the background mucosa, which would fulfill the first criteria of NICE for an adenoma, even though it's a serrated lesion.
That's right.
So moving on to type B errors, and these are the most common reasons for optical diagnosis error in small polyps. So the diagnosis is a serrated polyp optically, but in fact histology shows an adenoma. Why do we make that error?
So this was interesting. For type B errors, we identified that there are actually some adenomas that don't really meet the full NICE classification criteria, and in particular the colour aspect of that, because some adenomas actually have a similar or lighter colour than the background mucosa, and so this can result in a type B error occurring.
Are there any other reasons?
Yes, so there are a couple of other reasons that are related to the NICE classification, and particularly in possible misapplication of that. The first is where in a type 1 polyp you would expect to see lacy vessels, and these may be misinterpreted as the vessels of a type 2 polyp. And the second is that in a type 1 polyp you expect to see small white or black spots, and this could be misinterpreted as the oval structures that you would see in the type 2 polyp.
So this was the most common type of error. From our reading of this study, are there any ways that we could potentially improve and reduce that optical diagnosis error?
Yes, so one of the things that the NICE classification doesn't do is look at the morphology of the polyp. And so actually, if we take that into consideration, one of the useful signs first described by Rex et al. Is the valley sign. And this, although only present in a minority of adenomas, is highly specific for adenomas. And this basically describes the surface of a polyp where there appears to be a depression, but it actually has sloped edges to it. And that valley, when seen, is highly specific for an adenoma.
So let's move on to the type C error, where we think the optical diagnosis is adenoma, but histology shows something other than adenoma or serrated pathology.
Yeah, so in type C error, what we found is that inflammatory polyps were on occasion misdiagnosed as adenomatous, and that is because within the NICE classification, if applied to an inflammatory polyp, the colour typically is darker than the background mucosa, and the reason for that is because there is, within an inflammatory polyp, there's distortion of the crypts and increased vascularity, which results in that change.
But what can we do to double check that something might not be an adenoma when it is in fact an inflammatory polyp?
So in this case, the fibrin cap, it can be a useful marker to help distinguish an inflammatory polyp from an adenoma, and it's very easy to diagnose and could help to avoid type C error.
And the vast majority of inflammatory polyps will have a fibrin cap. So finally, let's look at type D errors. Optical diagnosis shows a serrated polyp, but histology shows other pathology which is not adenoma. What is happening here?
So in type D error, what we found is that there are some scenarios where, so what is actually seen is an inverted diverticulum, and that can give the appearance of a polyp. And in order to overcome this type of error, what we would suggest is to incorporate the aurora ring sign within the optical diagnosis decision making to help exclude these cases, but also to perform an endoscopic assessment using a forceps to see if the lesion inverts, for example, as well.
Yes, we certainly don't want to be snaring off inverted diverticular. So we've described in detail the four different causes for optical diagnosis error, or the four different types of optical diagnosis error. We've looked at some of the causes, but of course in day-to-day practice, in busy practice, there are other mundane reasons why we sometimes don't get it right. So for instance, we found on a number of occasions the NBI image just wasn't taken, or there was a clear misinterpretation of an obvious nice type 2 lesion. Have you got any tips, anything, Ahmir, that people can take into their practice which make optical diagnosis easier and more effective?
Yeah, so as part of the root cause analysis, there were 134 cases which underwent photodocumentation review, where there was a discrepancy between the high confidence optical diagnosis and the histology, even after deeper levels were analysed. And so what we found is that in roughly half of the cases that underwent photodocumentation review, there was actually an issue with the adequacy of the photodocumentation. And in order to overcome that and facilitate a high confidence optical diagnosis, we would suggest using the 3C photo quality checklist as an aid memoir to improve the quality of photodocumentation, which is a really important aspect when employing a resect and discard strategy. And so ensuring that a polyp that is photodocumented has a complete view, has a clean surface, and is correctly focused helps to optimize the photodocumentation. The second area where the photodocumentation review identified issues was where there was a mismatch in the NICE criteria, that you couldn't apply the NICE criteria fully. And so in those scenarios, we suggest the use of adjuncts such as the Bailey sign, the identification of pseudoadenomas, which we've described, and also the aurora ring sign and fibrin cap. So the third area that was identified as a cause of error was where there was an issue with the application of the NICE criteria, and in those cases that could be resolved by training, which would be part of the quality assurance process of an optical diagnosis approach. And finally, there were some cases where even after expert photodocumentation review, it was felt that pathology was still the underlying cause of error, as, for example, there was a high confidence adenoma, but which met all of the NICE criteria on photodocumentation review, but the histology came back as normal.
So presumably in that situation, the sections that were taken were not across the polyp?
Yes.
Or somehow there was a processing error?
Yes, so it's possible that if deeper levels had been performed in that scenario, that a polyp may have been identified if even more than 12 levels had been performed.
So, I mean, in summary, we've done this root cause analysis and looked in detail, involving our histopathology colleagues, to work out what we're actually looking at under white light and narrowband imaging, and highlighting some of the issues with optical diagnosis when a high confidence diagnosis doesn't correlate with the histology. We've described this new group of polyps, the pseudoadenomas, where serrated lesions have this tubular crypt but without vessels around the edge. And we've highlighted some of the problems with the NICE classification, particularly around colour and interpretation of vessel structures. We hope that this information will allow us to get more accurate algorithms around optical diagnosis. At the end of the day, the vast majority of high confidence diagnoses in the Discard 3 study were correct. But if we can get even more accuracy, this will give clinicians more confidence to be able to adopt an optical diagnosis resect and discard strategy in their day-to-day clinical practice. We've put together an algorithm which we think is helpful, using the most common and easy to use classification systems. It incorporates the NICE classification, our new finding of the pseudoadenoma, the use of the Valley sign, first described by Rex, which is extremely useful, and also adjuncts like fibrin cap and aurora ring sign. And hopefully you'll find this useful in your daily practice. So we very much hope that you enjoy reading our paper. Thank you for your attention.